Good day, everyone. Bonjour à tous. Welcome to the fourth webinar organized by Dairy Farmers of Canada's team of dietitians. Today's entitled The DASH Diet, Current State of Knowledge, featuring renowned researcher scientist Dr. Sally Chiu. My name is Angelique Berg, CEO of Hypertension Canada, and your moderator for today. This webinar was organized by Dairy Farmers of Canada in collaboration with Hypertension Canada. And together we are thrilled to welcome more than 2,000 registrants from coast to coast. Hypertension Canada is very proud to collaborate on this session and excited about the findings presented within it. We are best known for our evidence-based clinical practice guidelines for the prevention, diagnosis, treatment, and control of hypertension. Since their introduction in 2001, Canada's hypertension control rates have risen from 12% to lead the world at over 65%. Foundational among these strategies is the DASH diet, a key element in our health behavior management recommendations and in our public education. Over 7.5 million Canadians live with hypertension today, and another 7.5 have elevated blood pressure that will advance to hypertension without health behavior management. For all of these 15 million Canadians, the DASH diet presents an opportunity to control blood pressure and to improve and prolong their health. So we're eager to learn from these findings today, and let's get started. To download the presentation, simply click the link at the bottom of your screen. Note that a Q&A period will follow the presentation, but you can ask your questions at any time. We'll try to answer as many as we can. Si vous le désirez, nous offrons un service de traduction simultanée de l'anglais au français. Voir le bouton à cet effet au bas de votre écran. Now I'm pleased to introduce Dr. Sally Chiu. Dr. Chiu received her PhD in nutritional biology from University of California, Davis, and is currently a research scientist at Touro University, California, and also holds an associate staff scientist appointment at Children's Hospital Oakland Research Institute. At this institute, Dr. Chiu studied the effects of dietary carbohydrates and dairy fat on lipid and lipoprotein risk factors for cardiovascular disease for over a decade, most recently focusing on the effects of incorporating high-fat dairy into recommended dietary patterns, including the DASH diet. In her current position at Touro University, Dr. Chiu is studying the effects of dietary sugars on lipid and glucose metabolism and also manages the Metabolic Research Center, which provides clinical research support to investigators conducting studies in metabolic diseases. Dr. Chiu.
Thank you, Angelique, for the introduction. Welcome, everyone, and thank you for joining the webinar today. My talk will describe the current state of knowledge of the DASH diet in relation to its effect on blood pressure as well as lipid risk factors. I hope that by the end of the talk, you will have a good grasp of the DASH diet and its benefits, as well as ideas on how to implement the diets in practice. Here are my disclosures, which include various funding sources for investigator-initiated research grants. For my talk today, I will briefly first introduce hypertension, its definition and prevalence in Canada. Then I will spend some time going over the major studies testing the DASH diet and its effect on cardiovascular risk factors, focusing on blood pressure as well as lipid risk factors, which is my area of research. We will review the original DASH trial, studies using DASH-like or DASH-style diets that differ in macronutrient content or food group servings, and meta-analyses and endpoint analyses of studies assessing the DASH diet. Then we will look at how the DASH diet fits in with current dietary recommendations. And finally, I will outline some challenges and strategies for implementation of the DASH diet. As you know, high blood pressure is associated with cardiovascular disease, kidney disease, and increased mortality. Hypertension-related deaths are primarily due to cardiovascular disease, which include heart attack, stroke, heart failure, and peripheral vascular disease, as well as kidney failure and dementia. High blood pressure also tends to cluster with other metabolic dysfunctions, such as obesity and insulin resistance. Thus, it is necessary to accurately identify and manage high blood pressure. In regards to hypertension and its definition and diagnosis, Shown here is the algorithm reflecting the guidelines for diagnosis put out by Hypertension Canada. For non-diabetics, this includes an automated office blood pressure measurement of greater than 135/85 or non-automated measurement of greater than 140/90 with follow-up blood pressure measurements, either ambulatory or home measurements, to confirm office readings. For diabetics, a lower threshold of greater than 130/80 is recommended for a diagnosis of hypertension. In the United States, the recommendations for a diagnosis of hypertension is currently a blood pressure of over 130/80. Management depends on risk and includes behavioral changes, including diet and pharmacological treatment. For those hypertensive with a lower risk, diet is often recommended as the first line of treatment. These data show the current estimated rates of hypertension in Canada, which, as you can see, increases with age. Virtually half of Canadians 65 and older are hypertensive. Men have higher rates of hypertension than women until about age 45. From about 45 to 65, rates are similar between men and women, and after 65, more women than men are hypertensive. Data from Canadian population surveys indicate that about 83% of hypertensives are aware that they have hypertension, 78% are being treated, and about 65% have their hypertension adequately controlled. In Canada, control rates among diabetics are a little lower. However, hypertension control rates in Canada are higher than other industrialized countries. Globally, it is estimated that 40% of adults have hypertension, and this equals about 1 billion people. These rates vary by race and ethnicity. In particular, African Americans have higher rates of hypertension than Caucasians in both sexes and at all ages, and their hypertension tends to be more severe and more difficult to control. In the upper panel are trends in the rate of hypertension among men and women in Canada, both in absolute rates and as age-adjusted rates. You can see a steady rise in hypertension rates over time. Some potential explanations for the continuing rise include increased awareness and detection, an increase in the prevalence of obesity, and an aging population. In 2010, it was estimated that hypertension-related medical costs totaled $14 billion, or 10% of Canadian healthcare spending. In the bottom panel, we see that the number of prescriptions for blood pressure medications have increased at the same time that drug costs have fallen. Wouldn't it be nice if a portion of the drug prescriptions could be reduced or eliminated with better diet management? That segues us into our discussion of managing hypertension and cardiovascular disease risk through diet, focusing on the dietary approaches to stop hypertension diet, or DASH diet. We're all familiar with the basics of the DASH diet, which is high in fruits, vegetables, and dairy products. This dietary pattern was developed as part of a large clinical trial in the 1990s that aimed to develop and test diets for blood pressure reduction. It remains the most widely prescribed dietary intervention for the prevention and management of hypertension and cardiovascular disease risk. This chart outlines the recommended servings of major food groups for the DASH diet per 2,000 calorie intake. It is a relatively high carbohydrate diet at about 55 to 57% total energy and is low in total and saturated fat. It includes 4 to 5 servings each of fruits and vegetables, 2 to 3 servings of dairy products, the inclusions of nuts, seeds, and legumes, and 2 or few servings of meat. Let's now review the data from the original DASH trial. Based on the results from previous research on the effects of dietary components and blood pressure lowering, investigators created 2 dietary patterns they hypothesized would decrease blood pressure in comparison to a typical Western diet. These were a diet high in fruits and vegetables and a diet high in fruits and vegetables and dairy products, which they called the combination diet. The combination diet is what we now refer to as the DASH diet. These diets were tested in 459 individuals with elevated diastolic blood pressure who were randomized to consume one of the diets for 8 weeks. Participants had elevated diastolic blood pressure and systolic blood pressure less than 160. The study provided participants with all study foods to be consumed, and 1 meal a day on weekdays was eaten on-site to increase compliance. Calorie consumption was adjusted as needed to maintain a constant body weight. The DASH trial is considered a very large controlled feeding study. The control Western diet was low in fruit, vegetable, and dairy intake and high in refined carbohydrates and fats. Both the fruits and vegetables and the combination DASH diet had 8 to 10 servings of fruits and vegetables and the inclusions of nuts and seeds. The fruits and vegetable and combination DASH diet differed primarily by the addition of about 3 servings of dairy products per 2,100 calories in the DASH combination diet. This included some full-fat dairy equaling about 30 grams of cheese. There is also a reduction of meats in the combination diet in comparison with the other 2 diets. Note that over half of the servings of fruit were given in the form of 100% fruit juice. This was back in the 1990s, and I think now most of us would discourage that amount of fruit juice consumption. In terms of nutrient targets, the Western and the fruits and vegetable diets were higher in total and saturated fat, while the DASH combination diet was low in total fat and saturated fat. In exchange for total fat, the DASH diet was a bit higher in carbohydrates. By design, the control Western diet was lower in potassium, magnesium, and calcium, which represented the 25th percentile of U.S. intake at the time. The fruits and vegetable diets had potassium, magnesium at the 75th percentile of U.S. intake, as did the combination diet. With the inclusion of dairy, the DASH diet had higher calcium, which is about the 75th percentile of U.S. intake. Fiber was higher on the fruits and vegetable and DASH combination diet at about 31 grams versus 9 grams in the Western diet. Here are the results of the diets on systolic and diastolic blood pressure, shown as weekly measurements. Both the fruits and vegetable diet and the combination DASH diet lowered systolic blood pressure and diastolic blood pressure, but the combination diet had about double the effect of the fruits and vegetable diet. Notice that blood pressure reduced rather quickly into the intervention within 2 weeks and plateaued for the remainder of the study. When investigators did a subset analysis, the greatest blood pressure reduction was in hypertensive subjects on the combination diet, with a reduction in systolic blood pressure of 11 and diastolic by 5.5. This is an amount comparable to drug therapy. The blood pressure lowering effect was also significant in the non-hypertensive subjects, although it was more modest, as one would expect. Going forward, I will refer to the combination diet as the DASH diet. The DASH diet, by way of its reduced saturated fat content, reduced total and LDL cholesterol, but it also reduced HDL cholesterol. It had no effect on plasma triglycerides when compared to a Western diet. In addition to its effect on blood pressure, the DASH diet may reduce coronary risk through decreasing LDL cholesterol, but it is not known how the accompanying decrease in HDL cholesterol may lessen the potential risk reduction. Since the original DASH trial was published, followed by promotion of the DASH diet as a healthy eating pattern, there have been several studies testing the effects of variations in the DASH diet. The first study I'll talk about is the Optimal Macronutrient Intake Trial, or OMNI-Carb Trial, which was conducted by investigators from the original DASH trial study research team. Investigators tested 3 DASH-style diets that varied in macronutrient content to test the effects of replacing carbohydrate with either protein or unsaturated fat in 164 adults with pre-hypertension or stage 1 hypertension. Of the 3 diets, the carbohydrate diet was most similar to the DASH diet. The protein diet replaced 10% of energy of carbohydrate with an additional 10% of energy from protein, primarily from plant protein. For the unsaturated fat diet, fat increased by 10%, primarily by using monounsaturated fats, with a concomitant reduction of carbohydrate by 10%. Everything else was held as constant as possible across the 3 diets. Participants consumed all 3 diets for 6 weeks each. As in the original DASH trial, all study foods were provided to participants, and they were required to consume 1 meal a day on site. Weight was kept constant. Looking at the blood pressure results, all 3 DASH-based diets reduced blood pressure. The results shown here are for those participants with stage 1 hypertension, which is the subset showing the greatest effect. The trends were similar for those with prehypertension, but the effect was much smaller in magnitude. Replacement of 10% energy from carbohydrate with either protein or saturated fat reduced blood pressure to a greater extent than the carbohydrate diet when compared to baseline. Blood pressure lowering did not differ between the protein and the unsaturated fat diets. For those that started out as hypertensive at baseline, only 38% were still hypertensive after the carbohydrate diet. 22% remained hypertensive on the protein diet, and 19% remained hypertensive on the unsaturated fat diet. Investigators measured the effects of the 3 DASH-based diets on lipid risk factors. Replacing 10% of carbohydrate in DASH with protein or unsaturated fat lowered triglyceride levels, shown in red, which is consistent with the known effect of carbohydrate lowering. The protein diet had an additional effect of reducing LDL-cholesterol further than the carbohydrate diet, but it also reduced HDL cholesterol by a small amount. The unsaturated fat diet lowered plasma triglyceride, but without also lowering HDL cholesterol. Therefore, replacing carbohydrate in a DASH-like diet, either with protein or unsaturated fat, primarily from monounsaturated fat, modestly improves blood pressure, retains the LDL cholesterol lowering effect of the DASH diet, and reduces triglyceride levels. Subtle difference on their effects on lipoprotein risk factors may offer dietary choices for individuals based on their own risk profile. A follow-up to the OMNI-Heart study is called the OMNI-Carb study, and this study tested the effects of higher or lower carbohydrate amount and higher or lower glycemic index within DASH-style diets on cardiovascular disease risk factors. They did this in 163 overweight adults with systolic blood pressure between 120 and 159. Participants consumed all 4 diets for 5 weeks each, and all foods were provided as in the previous trials. The glycemic indices were chosen to reflect the first and fifth quintiles of U.S. intake. Some examples of the exchanges they made between the high glycemic index and low glycemic index diets included instant potatoes versus pasta, instant oatmeal versus steel-cut oats, and white versus whole bread. Please focus your attention to the plots at the top of the slide for systolic and diastolic blood pressure. There was no effect of either total carbohydrate amount or glycemic index on systolic blood pressure. If the line on either side of a dot crosses the 0 line, then that means the effect is not significant. And you can see that for systolic blood pressure, all the comparisons have plots that cross the 0 line. For diastolic blood pressure, there was no effect of low versus high glycemic index, but low carbohydrate content did reduce diastolic blood pressure more than the high carbohydrate content diets, but very modestly by about 1 millimeter of mercury. For LDL cholesterol, the first comparison shows that replacing high glycemic foods with low glycemic index foods actually increased LDL cholesterol. This was unexpected and very surprising to the authors. In the lower table, you can see the actual values of systolic blood pressure, and that all 4 DASH-based diets reduced blood pressure very well, but none were better than any other. Thus, lowering glycemic index within a DASH-like diet does not improve blood pressure and may actually increase LDL cholesterol. We've talked so far about shifts in macronutrient content within a DASH-based diet, but there have been a few studies testing whether variation in DASH food group components could be effectively modified within the DASH diet. Our research group became interested in the DASH diet in part because we have long studied the effects of carbohydrate and saturated fat, primarily dairy-derived, on lipid risk factors. Since DASH has a relatively high content of carbohydrate and is low in saturated fat, we sought to see whether we could allow for greater saturated fat intake by reducing carbohydrate content. This was of interest in part because diets low in total and saturated fat content have been shown to be more difficult to follow and have lower adherence. We wanted to know if this modification of DASH could improve lipid parameters that are part of the atherogenic lipid profile. This is a clustering of lipid factors, including high triglycerides, low HDL cholesterol, and elevated small, dense LDL particles. We wanted to know if this diet could improve the atherogenic lipid profile while retaining the DASH benefits on blood pressure. Before I talk about our modified DASH study, I wanted to give 2 slides of background on lipoprotein subclasses, which is our group's area of research interest. First, I want to introduce you to the atherogenic LDL particles that we are interested in. LDL cholesterol is carried by distinct LDL particles that differ in physical properties and associations with cardiovascular disease risk. Medium particles make up the largest proportion of LDL particles in healthy individuals. Smaller particles have properties that make them more atherogenic, including reduced clearance from the blood, greater entry into the artery, and faster oxidation. Elevated levels of small LDL are associated with obesity, diabetes, high triglycerides, and low HDL cholesterol. The distribution of subclasses varies widely among individuals and is independent of total LDL cholesterol levels. The traditional lipid panels do not distinguish between larger and smaller LDL particles. Like LDL, the other lipoproteins, including HDL and VLDL, very low density lipoprotein, are also composed of subspecies with varying properties. In a previous study that our group conducted, we looked at the effect of saturated fat, primarily derived from dairy products, on the plasma levels of the different subclasses of LDL particles. This study was done on the background of a low carbohydrate diet, and saturated fat was exchanged for monounsaturated fat. The red circles represent the low saturated fat diet, and the blue circles are the high saturated fat diet. The difference between the two represent the specific effect of replacing monounsaturated fat with saturated fat, primarily derived from dairy. Looking at LDL cholesterol, it is well known that high saturated fat intake increases LDL cholesterol as well as HDL cholesterol. When you look at which particles contribute to that higher LDL cholesterol level, which are shown in the 3 sets of data on the right, it is the large and medium LDL particles that are increased with higher saturated fat intake, but not the small, dense LDL particles. This differential effect on LDL particles may in part explain why there is not a more robust relationship between increased saturated fat intake and cardiovascular disease outcomes. Going back to our high-fat DASH study, here is the nutrient breakdown of our test diets. The Controll, Western, and Standard DASH diets were modeled off the original DASH trial diets. For the high-fat DASH diet, we aim to reduce carbohydrate content, primarily by reducing fruit juices and easily digested carbohydrates from a standard DASH diet, and in turn, increasing the fat content, primarily through replacing low and non-fat dairy products with full-fat dairy products, such as whole milk. If you remember, the original trial provided half of the fruit servings as juice, and those were the carbohydrates that we aimed to reduce. We kept all other aspects as similar as possible between the 2 DASH diets, including potassium, magnesium, and calcium levels. We studied 36 men and women with elevated diastolic blood pressure and systolic blood pressure less than 160. This was similar to the patient population in the original DASH trial. Participants consumed all 3 test diets in random order, separated by a 2-week washout where they returned to their regular diets. We developed detailed menus and provided about 50% of the study foods. Participants were provided detailed shopping lists for the remaining foods, which were mostly packaged grains, fresh produce, and dairy products. Blood pressure was measured on several occasions in the clinic as well as at home by the participant. Both the standard and the high-fat DASH diets reduced blood pressure compared to the Western diet as measured in the clinic or at home, with no significant difference between the two DASH diets. Therefore, a high-fat DASH diet retains the same blood pressure benefit as a standard DASH diet. Our blood pressure reduction was just slightly lower in magnitude than the original DASH trial, and this may reflect a tighter control of compliance in their trial where all food was provided and participants were required to eat meals on site. As expected, when we compared our standard DASH diet to the Western diet for lipid risk factors, we saw a decrease in total and LDL cholesterol, as well as apolipoprotein B, which is the protein associated with LDL cholesterol. There was also a decrease in HDL cholesterol and its associated apolipoprotein, ApoA1. In our study, we also saw a significant increase in plasma triglycerides with a standard DASH diet compared to a Western diet. When looking at the different sizes of LDL particles to the right, the standard DASH diet reduced the large LDL particles, which are those that are less strongly associated with cardiovascular disease risk. However, small dense LDL levels, which are more strongly associated with cardiovascular disease risk, were not significantly changed by a standard DASH diet. When we compare the high-fat DASH diet to the standard DASH diet, we see a reduction in plasma triglycerides. This is likely driven by the reduction in carbohydrate in our high-fat DASH diet. But we saw no increases in LDL cholesterol or apolipoprotein B, despite a higher saturated fat content. There may be a feature of the DASH diet that mitigates the usual saturated fat-induced increase in LDL cholesterol. Lipid risk ratios, including triglyceride over HDL cholesterol and total over HDL cholesterol, were reduced on the high-fat DASH diet compared to the standard DASH diet. This suggests that the high-fat DASH diet can modestly improve triglyceride and lipid risk ratios without an increase in LDL cholesterol. If we look at the lipoproteins that contribute to the differences, we find that LDL size is significantly increased. That's the first bar. This is the size of the most abundant LDL particle in the plasma. This size increase is reflected by a shift in smaller LDL particles to larger LDL particles with a high-fat DASH diet compared to the standard DASH diet. We see a reciprocal decrease in triglyceride-rich medium and large VLDL particles, which reflects the reduction in triglycerides we saw on the high-fat DASH diet. In summary, a DASH-like diet modified to allow for more liberal intakes of total and saturated fat, primarily derived from dairy, in conjunction with a reduction in carbohydrate, results in comparable blood pressure reduction and improvements in plasma triglyceride compared to the standard DASH diet. Despite its higher saturated fat level, the high-fat DASH diet did not raise LDL cholesterol or small dense LDL particles compared to a standard DASH diet. The DASH diet pattern promotes limited intake of red meat. I'll discuss two studies investigating the incorporation of greater amounts of red meat into a DASH-like diet. The Beef in an Optimal Lean Diet, or BOLD study, tested the effects of DASH-like diets with lean beef on blood pressure and plasma lipids. Authors were interested in beef in part because of the mixed association between red meat and cardiovascular mortality. They surmised that the wide variation in fat content between different cuts of beef may contribute to inconsistent results. They studied 36 subjects who consumed 4 diets for 5 weeks each, including a healthy American diet, a DASH diet, and 2 DASH-based diets incorporating servings of lean beef. This involved partially substituting the poultry, pork, and fish in the DASH diet with lean beef for the BOLD diet, or with additional vegetable protein and beef for the BOLD Plus diet. Because of its increased protein content, the BOLD Plus diet had a lower carbohydrate content. All of these DASH-based diets were low in saturated fat content. In terms of blood pressure, only the BOLD Plus diet, which had higher total protein content, including 5.4 ounces of beef, was associated with a decrease in systolic blood pressure, that's the purple column, compared to the healthy American diet. There was no difference between the healthy American diet, the DASH diet, or the regular BOLD diet for systolic blood pressure, and there were no differences among any of the tested diets for diastolic blood pressure. This lack of effect of the DASH-based diets compared to the healthy American diet may be due to the fact that subjects were normotensive, with an average baseline systolic blood pressure of 116, and that this was a rather small study. You can see that the blood pressures on the different diets are all in a very healthy range. Looking at the effect of these diets on lipids, incorporation of lean beef into a DASH diet elicited favorable lipid effects, which were comparable to the DASH diet. These effects are all likely driven by their low saturated fat content. There was a lot of variability in the triglyceride levels, and none were significantly different from the healthy American diet. The recommendation to limit meat in DASH may be in part due to concerns of accompanying sodium and saturated fat. Authors caution that individuals must be cognizant about which cuts of beef are leanest when incorporating beef into the DASH diet. Examples of accessible lean cuts include top round steaks, top sirloin, bottom round roast, and 95% lean ground beef. Thayer et al. Tested whether replacing chicken and fish with lean pork in a DASH-like diet would retain blood pressure benefits in 19 individuals with elevated blood pressure at baseline. The test protein was just over half of the total protein. The pork diet included pork tenderloin and uncured ham and equaled about 2 servings for the 2,100 calorie level. The bottom table shows the blood pressure results. There was a similar reduction in blood pressure with the pork-containing or the chicken and fish-containing DASH diets compared to pre-diet values, with no significant difference between the two DASH diets. Thus, it appears that both pork and beef can be incorporated into a DASH diet without significantly altering the effects on CVD risk factors, including blood pressure. The DASH diet is among the most well-studied diets, making meta-analyses on its efficacy possible. Meta-analyses are statistical tests that take the data of several separate but similar experiments and pool them to look for an overall effect. In a meta-analysis of randomized controlled trials investigating diets for blood pressure reduction, the DASH diet had the largest effect on lowering blood pressure compared to the other included diets, which included low sodium, low calorie, and the Mediterranean diet. This reduction was about 7.6 millimeters of mercury for systolic blood pressure and 4.2 for diastolic blood pressure. A separate meta-analysis was performed on the effect of DASH diet on lipid risk factors. There was an overall significant effect on reducing total and LDL cholesterol when data across all 17 trials were considered. This represented over 1,900 participants. With its effect on blood pressure, these changes predict a 13% decrease in the 10-year Framingham risk score for cardiovascular disease. Thus far, we have been discussing the effects of DASH on risk factors, but more importantly, we would like to know how following the DASH diet can reduce morbidity and mortality. The Nurses' Health Study and the Health Professionals Follow-Up Study are two large prospective studies that assess participants' diets periodically through surveys and track the occurrence of endpoints such as cancer, cardiovascular disease, and death. In this analysis, those who had low baseline DASH scores who improved their diets substantially to achieve high DASH scores 12 years later saw a significant decrease in the risk of death. This improvement in diet quality was described by authors as a 13 to 33% improvement in DASH score, so relatively modest. While on the contrary, those who saw a worsening of diet quality over time had an increased risk of death. Thus, moderate diet improvements over time can truly be meaningful. Now that I've described to you the evidence for benefits of the DASH diet, we will now talk about how to approach implementing the DASH diet in our patient populations. One question you may have is, how does the DASH diet fit in with current recommendations? If you look at Canada's food guide, there are some differences in the recommended servings compared to DASH. For example, DASH recommends more fruit and vegetable servings at about 8 to 10, as well as more servings of dairy. However, DASH is for the most part consistent with what is recommended. And in the U.S., the DASH diet is one of the healthy eating patterns recommended in the 2015 Dietary Guidelines. Many agencies in both the United States and Canada endorse and recommend the DASH diet for the prevention and management of chronic disease, such as hypertension and cardiovascular disease. These include Hypertension Canada, the Heart and Stroke Foundation of Canada, Diabetes Canada, Canadian and U.S. guidelines for the treatment of high blood pressure, the American Heart Association, and as I mentioned, the 2015 Dietary Guidelines for Americans. So, how do we implement the DASH diet? Well, despite documented benefits of the DASH diet, adherence on a population level is low. In 2016, only 30% of Canadians greater than 12 years old reported eating fruits and vegetables 5 or more times per day. And in the same year, average consumption of dairy products was about 1.75 servings per day. In the U.S., it's not much better at 1.9 servings per person per day. And data from the NHANES survey from 2007 to 2012 showed an average DASH adherence score of 2.6 out of 9. Sadly, this score was worse than when DASH was first introduced in the 90s. Before we devise how we can help people do better, we can look back at the DASH studies to help tease out barriers to compliance. We know that there was excellent adherence in the DASH feeding trials in which food was provided and participants were required to eat one meal on site per day. This was in the range of about 95% compliance. In the original DASH trial and many of the subsequent trials, this compliance was very high at about 93 to 97%. This is certainly not feasible in practice to have participants and patients coming in to eat one observed meal per day. A review of compliance to DASH diets in research studies showed that adherence to the DASH diet is generally low when only counseling was given without providing foods. As an example, in one study, 21% of adolescent participants achieved DASH targets for fruits, vegetables, dairy, and saturated fat with counseling in a 3-month study. In a separate 12-week study, showed that 60%, 67%, 48%, and 89% of male adults met the targets for fruits, vegetables, and dairy, respectively. This also shows that some DASH targets, such as dairy, may be easier to implement than, say, meeting the recommendations for vegetable servings. Most all studies show a decrease in compliance over time, which is true with virtually all behavior modifications and a challenge for practitioners. Analyses of these challenges unfortunately show no consensus over the best approach to improve compliance. And also, there is no standardized way to measure compliance. Some studies use urinary excretion to measure dietary intake, and some of the DASH scores are very widely between how they are calculated, which makes comparing study to study rather difficult. Nevertheless, some adherence is better than none. It is estimated that for every 2-point increase in the DASH score out of a possible 10, systolic blood pressure will be lowered by 3.4. There are several potential strategies for improving DASH adherence that I'll discuss today. One major strategy may be to increase flexibility and menu variety and be able to individualize DASH diets. In the original DASH trial, lack of menu variety was the primary reason for lapses in adherence. We just discussed ways in which the DASH diet can be varied by carbohydrate, fat, or protein content, or by the incorporation of red meats or full-fat dairy while retaining the blood pressure-lowering effect. These modifications may provide individuals with the flexibility needed for better dietary adherence. One concern is the availability and cost of DASH diet foods, which emphasize foods most often purchased and consumed fresh, which can be more expensive. Studies have shown that individuals with the lowest economic accessibility to supermarkets had the lowest odds of being DASH accordant. Although the solution to this may not be in the hands of the practitioner, but it is something to bear in mind when working with the individual or in communities. One suggestion has been to improve messaging and communication. In the PREMIER study, which tested whether free-living individuals could follow the DASH diet successfully, regular group and individual counseling resulted in meeting many of the DASH targets at 18 months, although, of course, not to the level of the original DASH trial. Finally, a multidisciplinary healthcare team may help to consistently communicate dietary goals to patients. A meta-analysis showed that only those dietary trials using registered dietitians to counsel hypertensive patients showed significant decreases in blood pressure. For those dietitians out there, continue to do your good work. And keep in mind that perfect compliance is not necessary to result in significant improvement in blood pressure and CVD risk. We really try to do our best. So in summary, hypertension affects about 25% of Canadian adults. Management of blood pressure through diet should be really a priority. The DASH diet is a dietary pattern high in fruits and vegetables and dairy products that lowers blood pressure and lipid risk factors compared to a typical Western diet. But despite demonstrated benefit, widespread implementation has really been challenging. Studies show that variations in the DASH diet plan can yield similar benefits to blood pressure and comparable or better effects on lipid risk factors. These include increased protein or unsaturated fat to replace carbohydrate, the inclusion of lean beef and pork, or the inclusion of high-fat dairy. These modified DASH-style diets may offer more flexibility and food choices to aid long-term adherence. I wanted to provide some resources available to you. These include links to sample DASH menus, and in many of the published DASH trials, you can find study menus in the supplementary information online, which may be helpful if you are interested in implementing any of the modified DASH-style diets. And I want to thank you all for listening, and we will open for questions.
Thank you very much, Dr. Chiu. This is Angelique, your moderator, speaking again. Dr. Chiu, this was an outstanding presentation, and I want to thank you for it. One of the thoughts that I had as I was watching the screens is how much we know, and yet how low the adherence is when the benefits are clearly so great. And at first that's disheartening, but then your quote, which was along the lines of perfection is the enemy of good, so keep doing what you're doing, I found that so encouraging. So thank you very much. We do have some questions coming in. The first question, was there caloric restriction in either of these diets in the original DASH diet study?
So no, in the original DASH trial, the aim was to keep weight the same. So they would alter calorie intake based on weight taken throughout the study. There have been trials that have looked at DASH counseling plus weight management, and they do know that the addition of weight loss to a DASH diet further benefits blood pressure.
Excellent. Thank you. The second question from our audience, what was the contribution of dairy products to the blood pressure lowering effect?
So that is a really good question. It's with the DASH diet, it's really quite difficult to tease out the components that contribute to the blood pressure lowering effect. And one of the reasons they did this study is because previous research had looked at individual components here and there to try to figure out what might be effective for blood pressure lowering. And it's really the DASH diet together that seems to be the most effective. Now, dairy has been suggested to. I think when they look at the contribution, dairy is estimated to be, and I might have to look this up, but dairy is estimated to contribute about 50% of the blood pressure lowering. And this might be through the nutrients within, the vitamins and minerals within milk, or it could be the bioactive peptides that are potentially in dairy products as well.
Excellent. Thank you. Question number 3 from our audience. What about the new recommendation of not limiting salt at all for the regular population? This, I know, is a hot topic, certainly within Hypertension Canada's network, but there is quite a debate about that. Any thoughts on that?
I have no clear thoughts on it. You know, they did do a sodium trial looking at 3 different levels of sodium within DASH diets, but I know that for the general population, this is kind of a debate going on, and I don't know if you have some thoughts into that. That might be interesting.
We do, certainly. Hypertension Canada has got quite a work group around sodium, and we've come up, of course, with the recommendation to limit sodium intake to 2,000 milligrams per day for the hypertensive population, and then Canada's food guide is 2,300. So we're always looking at that, and there are some new studies coming out that I can surely send out if people are interested. But it is a hot topic for sure. We do know that sodium reduction is a key to lowering blood pressure.
Yes.
We have another question. Let's see. All right. So there's a question about resources here. Is there a DASH diet score sheet that you know of that could be used with clients?
So I actually did a little bit of research into that before the seminar, and it looks like at some point years ago, someone was trying to make sort of like a DASH food frequency, but that isn't available. And if you look at all these studies, the DASH score is unfortunately calculated different from study to study, but they are most of them are using a typical food frequency questionnaire and then pulling out the important aspects of DASH: fruits and vegetables, dairy, nuts, saturated fat targets, and then compiling a score. So that's really one of the challenges, is that we don't have a standardized way to measure how well people are doing with the DASH, in practice.
That's interesting. I wonder if there's an organization who might pick up that idea.
Yes.
Another one of those adherence strategies.
Yeah.
Another question. Is weight loss possible while following the DASH diet?
Yes, it is. And so the study that I mentioned that they did using DASH diet plus weight loss counseling yielded significant results. And so it is absolutely possible to follow DASH in a hypocaloric manner. Yes.
Great. And along the lines of the sodium question, another question is, what is the role of potassium in controlling blood pressure?
So potassium is one of the key factors that is likely contributing to the reduction in blood pressure, and it's actually what many of us in the research groups measure as urinary compliance to test for compliance to the DASH diet. And so I don't know sort of what the percentage of contribution is, but that potassium is one of the main players in the blood pressure reduction for the DASH diet.
And actually, Hypertension Canada just added increasing intake of potassium to our guidelines 2 years ago.
Oh, wonderful.
So we're pretty excited about that, and pretty excited about thinking, how do we do this, and how encouraging. What would you say are some of the best natural sources of potassium for people looking to increase their intake?
Oh gosh, fruits and vegetables would be, I think, really good choices. Your audience may know better than me individual potassium sources, but I can get back to you on that, and we can compile a list.
Great. Thank you. Looking for another question here. One of the other questions here is that does the DASH diet in combination with medication provide even more benefits?
I think they do act in concert or somewhat additively. Most of these studies, interestingly, were done in individuals who were not taking hypertensive medicine because it sort of messes up with the effect that you're looking with. But when they do trials in free-living individuals who are on blood pressure reduction medications already, they do see an additional benefit of DASH. So I think implementing both would be helpful with blood pressure management if needed.
Excellent. And our guidelines recommend first our health behavior recommendations first, and then adding that medication. So I think that question there is really relevant to that.
Yeah.
Another question: Are there studies on the med diet and blood pressure?
Yes. So I showed you that that one meta-analysis that looked at the different types of blood pressure lowering diets that have been studied, and the Mediterranean diet looks like it has a small amount of blood pressure lowering, but much less than the DASH diet. So there have been some studies looking at that, but it looks like it's not as effective as the DASH diet.
Dr. Chiu, with all of the research that you presented and the research that you've been doing over the last decade or so, what have you found to be the most encouraging that you would want to impart to the dietitians and the professionals that are on the line today? What were the most exciting findings that you've come across?
Well, for us, we are really interested in ways in which we can make the diet more accessible to people. Even in our clinical trials, we have issues with compliance. And really, if you don't follow the diet, you're not going to see the benefits. So I think in all of our research, looking at the possibility of modifying these diets, taking this very well-studied diet and then modifying it and showing that it still retains a lot of its benefits, that gives you a tool to bring back to your patient to tailor and individualize the diet for them. And hopefully that will help with adherence and getting towards your dietary goals. I think finding as many diets that are heart healthy will really help with the population adherence to a healthy eating pattern.
Thank you so much for that insight. Another question, actually, I think I have two more questions to ask.
Okay.
With respect to full-fat dairy, you referenced full-fat milk, 3.25%. What about regular cheese with milk fat at 30%?
So we used, in our study, when we replaced low and non-fat dairy products with full-fat dairy products, in all our studies, actually, that we've done, we usually do a combination of full-fat milk, full-fat cheese. So we'll use full-fat cheddar cheese versus full-fat cottage cheese. We also use full-fat yogurt versus non-fat yogurt. We try and not, load the diet too much with butter as our fat source, but kind of use a variety of dairy products.
Just building off that, there was some conversation among Hypertension Canada's network about the concern about most people getting eating their dairy rather than drinking their dairy. Did you find anything about that?
Interesting. So there is some research looking at cheese versus milk versus butter. There's not a lot of research out there. But there are some indications that cheese, at least for lipid risk factors, might be a little bit better. Yogurt, fermented products also have been sort of a hot topic, and those could potentially be more beneficial in part due to their effects on the gut bacteria. So I think people are really interested in the different types of dairy, but there is not a whole lot of research yet to definitively say if one is better than the other.
So then the takeaway there is adherence to the DASH diet, which of course is the number one challenge for us as adherence once we get home.
Yes. Yep.
Another question. What are some of the mechanisms to explain the beneficial effects of the DASH diet?
So that's a good one. So the potassium, magnesium, calcium, those are minerals that may aid in the reduction of blood pressure. I mentioned there might be milk or dairy biopeptides that also might be involved in lowering blood pressure. And I think beyond that, I'm not sure they know what the mechanisms are because the DASH diet kind of works in concert with all the different food groups. I don't know if you have more insight into that.
We do have some. We have been working on some patient resources to help, but again, that explaining the benefits seems to help. What we've learned in our patient focus groups and our market research is that, contrary to what we think, that people don't want to be scared, they do. They want to be scared into the state. People really do want to know what the downstream complications of high blood pressure are to motivate adherence. So we have a lot more work to do on that, but I think doing the problem and the benefit is probably a good coupling. That's what we're finding with our own research.
Interesting.
Okay, next question. Would you recommend portfolio or DASH diet to reduce blood pressure?
That's interesting. So there's much less research on the portfolio diet, which is, it's not super different from the DASH diet. So for now, because you want to go where the research leads you, I personally would recommend the DASH diet because there is this huge amount of research behind it.
Great, thank you. I've got another dairy-related. Aren't high-fat sources of cheese very high in sodium? How does that play a role in the DASH diet?
Oh, that's an interesting question. I don't actually know if all high-fat cheeses are also high in sodium. So my guess is you would have to make your choices very carefully and vary the high-fat dairy products that you're using in the diet. So you do have to be cognizant that your sodium's not going too high, and that if you're incorporating high-fat dairy, you might need to be aware that the sodium level could be higher in certain types of cheeses.
Thank you. Next question. How can the DASH diet be incorporated or adapted for patients who also have diabetes and renal disease? For example, limited potassium diet for those with hypokalemia.
That's interesting. So this would be a tricky puzzle for the dietitian to put together a menu that would meet the needs of the individual. And this would have to be, you would have to do some puzzling put together with different types of foods to make sure that you aren't, for example, having too high of a potassium level. And I think we've shown that you can tweak aspects of the DASH diet and still have blood pressure reduction, and that you just have to be careful of the individual components tailored to your patient. That's a tricky one.
That seems to be a recurring theme in the answers that you're giving, as well as in your presentation, about the importance of tailoring to the specific patient. I suppose that must be what makes the role interesting and intriguing as well for dietitians.
It does. Yes, they're very important.
Excellent. And I think that covers all of the questions that we have for today. Thank you so very much, Dr. Chiu, for all of your time and the preparation and that you put into this presentation and your time today from California. We really appreciate that.
Thank you so much for having me.
Thank you. Everyone, before you leave, please don't forget to complete the evaluation form and to print the certificate of attendance. On behalf of the Dairy Farmers of Canada and Hypertension Canada, thank you so very much for your participation. Have a great day, everyone.